Hey guys, welcome back to my channel, and today we will be discussing on renal tubular acidosis. Before we jump into the topic proper, if you like my channel, please subscribe and hit the bell icon next to it so that you get instant notifications whenever I post video. Renal tubular acidosis. This is a topic that scares most of us, to be very honest. And in the next few slides, I have tried to make it as simple as possible for us to understand renal tubular acidosis, approach a case of suspected renal tubular acidosis, and hopefully write an answer in your theory exams in case it is asked. The definition. As with any question, definition should be the first thing that you start with. For a renal tubular acidosis, the questions that are usually asked are a case scenario, and they will ask you to elaborate clinical features, investigations and treatment in renal tubular acidosis. So whatever it may be, you start with a definition. Definition will be a normal anion gap metabolic acidosis. This is the blood finding. Why does this happen? This occurs secondary to a tubular dysfunction, and this leads to this metabolic acidosis. Okay. Acidosis is either secondary to retention of hydrogen or loss of bicarbonate. I will tell you how this happens later on. There are 4 types. Earlier they used to classify as type 1, 2, 3 and 4. 1 and 2 are paradoxically named reverse. 1 is a distal tubular defect, whereas 2 is a proximal tubular defect. 3 earlier used to be a combination of 1 and 2, but now they are not used anymore. The other 2 types are hyperkalemic renal tubular acidosis. The first 2 are hypokalemic renal tubular acidosis. The third type is pseudohypoaldosteronism or aldosterone deficiency, that is resulting in a hyperkalemic type of RTA. The last variety is voltage dependent renal tubular acidosis, that is a variety of distal sodium reabsorption defect, but ultimately results in hyperkalemia. So just remember this: renal tubular acidosis, hypokalemic and hyperkalemic variety. Hypo is our classical distal and proximal RTA, which is what I will be discussing in the current lecture. Let us discuss some physiology so that we have a good understanding of the concepts in renal tubular acidosis. This pH 7.4. Now where did this 7.4 come from? The hydrogen concentration in our blood is 40 nanoequivalents per liter. Instead of putting so many zeros after a dot, what they have tried to do is they have tried to convert it in a logarithmic scale. pH is the log form of concentration of hydrogen ion. pH is inversely proportional to the logarithmic concentration of hydrogen ion. So when you put it as a formula, it ends up like this: minus log of point so many zeros followed by a 4. And the answer for that in a table is 7.4. Now why can't this be a easy 7? And why can't this be an easy 8? Why is it ending up as a 7.4? Because 7.4 is the concentration or pH that is required for most of our biological function, the most important of which is hemoglobin and oxygen relationship, and others. Most of the biochemical relations or reactions have intermediates. Those intermediates should remain in non-ionic form for them to continue in the reaction to form an effective product. But in an acidic environment, they become ionized, and hence they are not usable in a reaction. That is why this 7.4 is important, and it is tightly regulated between a narrow range of 7.35 to 7.45. Anything less than 7.35, even a 7.34, you call it as acidosis. Anything beyond 7.45, you call it as alkalosis. How is this 7.4 maintained in our body? They are maintained by 3 systems: the kidney, the lungs and buffer systems in our blood. They tend to keep the hydrogen, which is the acidic part, and bicarbonate, which is the main base part, in balance with each other so that our pH remains at a stable 7.4. We will start with buffer systems. The main buffer systems are phosphate, protein and hemoglobin buffers. Why am I starting with buffer systems? Because they act within seconds of any change in our acid-base balance. They do not eliminate the hydrogen ion per se. They make sure to bind with hydrogen ion so that it does not change our concentration in blood and keep them stabilized till our acid-base balance is re-established. So a buffer is any substance that can reversibly bind hydrogen ion. Next, our renal and pulmonary system. The next important one is lungs. Lungs, how do they act? They expire carbon dioxide. Now where did this carbon dioxide come from? Suddenly I am talking about carbon dioxide. Carbon dioxide is a part and parcel of our equation in acid-base balance. You will see this equation in our next coming lectures. Hydrogen ion always combines with a bicarbonate to form a carbonic acid, which again splits to form a carbon dioxide and water. For this reaction, the enzyme carbonic anhydrase is important. This carbon dioxide which is formed gets expelled through lungs. This compensation in case of an increase in hydrogen ion happens over minutes to hours, meaning if the hydrogen concentration ion in blood increases, it causes a metabolic acidosis. So what happens? The reaction shifts towards this side, causing increase in carbon dioxide. The carbon dioxide gets expelled through lungs, forming a compensatory respiratory alkalosis. Next is kidney. Though I am calling it last, this is not the least important. In fact, this is the most effective of acid-base regulators in our body. But the compensation happens over days because there are many complicated reactions that are happening within our tubules. Kidneys absorb bicarbonate, they excrete the excess hydrogen ion, and this compensation happens over a long time. We will see how it happens in the next slides. Let us talk about the role of proximal tubule. Remember, in proximal tubule, approximately 60% of all the electrolytes, your sodium, potassium, your amino acids, phosphates, most of them get absorbed in proximal tubule. As far as bicarbonate is concerned, nearly 90% of the bicarbonate that is filtered in glomerulus is absorbed here. So as you can see, our favorite reaction, your bicarbonate combines with this hydrogen ion which comes out via this sodium hydrogen exchanger. Why does this exchange happen? Because there is an electrochemical gradient that is created by this sodium potassium ATPase channel, meaning 3 sodium ions go out, 2 potassium ions enter. Since 3 are getting out from the tubular lumen, 1 sodium is entering here. Come on, where did my friends go? So it is following its friends. In that process, since a positive ion is entering, you need a positive ion exiting. That will be hydrogen. This hydrogen combines with this bicarbonate to form a carbonic acid. This is catalyzed by carbonic anhydrase reaction. This splits to form a carbon dioxide and water, which passively diffuses inside. Once it goes inside, the reverse happens. Here also carbonic anhydrase plays an important role. The bicarbonate which is formed and the hydrogen ion which is formed exits the cell like this. The hydrogen goes to lumen, the bicarbonate enters into interstitial fluid and ultimately your blood vessels by this sodium bicarbonate cotransporter. So the take home message from proximal tubule is most of the bicarbonate is reabsorbed here, most of everything else is reabsorbed here, and for every hydrogen ion that is secreted, 1 bicarbonate is reabsorbed into circulation. This is all I need you to remember. Coming to distal tubules. Distal tubules, there are 2 types of cells. There is a principal cell and there is an intercalated cell. Both are important for mainly hydrogen secretion. Okay, so proximal tubule, remember it is mainly bicarbonate reabsorption. The distal tubule is mainly hydrogen secretion, meaning for maintaining an acidic urine, your distal tubular function is very, very important. So here what happens? same sodium potassium ATPase pump. So here what happens? 3 sodium goes out. So the sodium from your tubule follows its friends. Since 3 sodium are exiting out and only 2 are entering in, there is a negative gradient here. That is what favors this sodium channel, which is the ENaC channel. I think you all remember ENaC channel from our physiology days, right? Correct. So this sodium enters into the cell and exits via the sodium potassium ATPase. Because so many sodium is entering into the cell, what happens in tubular lumen? It becomes electronegative. So what happens? The cell sends out potassium so that a neutrality can be maintained to some extent. This is also assisted by your aldosterone. Aldosterone, remember, causes sodium reabsorption and potassium excretion, and aldosterone increases whenever there is a hypovolemic state, to make it very simple. Next, coming to intercalated cells. Intercalated cells, remember, they secrete hydrogen. How do they secrete hydrogen? By 2 receptors. One is a hydrogen ATPase and the other one is potassium hydrogen exchanger. What exactly happens? So, the usual reaction that you see, your water splits into hydrogen and OH minus. The hydrogen exits through ATPase. Here it exchanges potassium inside. This is very, very important because whenever there is a the number and activity of these pumps are basically increased whenever there is a potassium depletion. So whenever there is a hypokalemia, this pump increases so that it can reabsorb more potassium in exchange for hydrogen, and the reverse happens whenever there is a hyperkalemia. Okay, and this side what happens? The carbon dioxide combines with OH minus to form your bicarbonate with the help of carbonic anhydrase, and bicarbonate enters into your capillaries through this chloride exchanger. A negative ion exits and a negative ion enters. The negative ion here is chloride. The acidification of urine is mainly dependent on this hydrogen secretion through ATPase and potassium hydrogen exchanger in distal tubules. So what happens to this hydrogen that exits your tubules, tubular cells? It combines with, of course, bicarbonate. It also combines with phosphate. It can also combine with ammonia or ammonium, to be very specific. Next, coming to anion gap. For you to understand anion gap, you need to know what are anions and what are cations. Cations are positively charged and anions are negatively charged. So the positively charged ions are main ions are sodium and potassium, whereas the negative are chloride, bicarbonate. Apart from them, there are so many unmeasured anions which are sulfates, phosphates, albumin, etc. Since they are very difficult to measure, you put them as unmeasured anions and you require them to be in a balance. If either of them increase, your whole system of positivity and negativity goes for a toss. So what is this anion gap? Anion gap is this unmeasured anions basically. So how do you know? You have to know that sodium, potassium and cations is equal to chloride, bicarbonate and unmeasured anions. So unmeasured anions or this anion, extra anion gap should be equal to sodium and potassium minus your negatively charged chloride and bicarbonate. So how much do you expect this unmeasured anion to be? 14 to 18 if you are including potassium in your formula. If you are not going to include potassium, it is going to be 10 to 14. So unmeasured anion or anion gap is 10 to 14. How do you account for this increased anion gap, normal anion gap, etc.? So whenever there is a loss of bicarbonate, as which happens in gastroenteritis, as which is happening in a renal tubular acidosis, the kidneys tend to increase your chloride reabsorption, essentially maintaining this balance. So you will not have a change in anion gap. I hope I am making myself clear. So you will have a normal anion gap metabolic acidosis. So according to our definition, there is a normal anion gap, because even though there is a loss of bicarbonate, your kidneys are compensating by increasing chloride absorption or retaining the chloride without secreting it, maintaining your anion gap. Coming to RTA proper. We will discuss about proximal RTA first and then go to distal RTA. I will be maintaining terms as proximal and distal so that we don't have any confusions. So in a proximal RTA, what happens? It is important for reabsorption of 90% bicarbonate, I told. Here that is not going to happen. Does it mean whole of the bicarbonate is lost in urine? No, it is not so. So our normal bicarbonate concentration is somewhere between 24 to 28 milliequivalents per liter. So whenever the bicarbonate concentration reduces in blood, say it comes down to 22 or 21, our tubules increase your bicarbonate absorption so that you can maintain bicarbonate at 24 to 28. So the threshold is anywhere less than 24. Clear on this? In proximal RTA, what happens is this threshold is reduced, meaning this child will start reabsorbing bicarbonate only at a level of say 16 or 14 instead of 24. So till the child reaches the blood bicarbonate level of 18, this child is going to continue to lose bicarbonate because the tubule need not reabsorb, because that is the normal for this particular proximal tubule. Okay, so there is a loss of bicarbonate, which is the hallmark of proximal RTA. There is also loss of rest of glucose, sodium, potassium, phosphates, uric acids, amino acids, etc., etc., etc. Okay, so what happens to urine pH here? This is important for us to understand. So you expect the urine pH to be alkaline, right? Because you are losing bicarbonate, it makes sense. But remember, here your distal tubules are functioning properly. So even though there is a loss of bicarbonate proximally, there will still be distal acidification happening. So your urine pH will tend to remain normal. And also, this is also dependent on whether this patient is going to receive alkali therapy or not. Meaning, it depends on the blood bicarbonate level. So imagine this child is receiving an alkali therapy, and because of that the blood bicarbonate level increases to 20, the normal. So and in this case what happens, the proximal tubule is not going to reabsorb any of the bicarbonate and all of them are going to be lost in urine. So the pH can remain alkaline. Suppose this child is not receiving an alkali therapy, what happens? The blood bicarbonate is going to be less, say around 16, which is less than the expected 18 for this particular proximal tubule. So this child will reabsorb bicarbonate. In that case what happens? The urine pH is going to remain acidic because distal acidification is happening. Clear? So urine pH is variable and dependent on whether this child is receiving alkali therapy or not. What are the causes of proximal RTA? Proximal RTA can be isolated, meaning just the proximal tubule is involved, or rather just the bicarbonate part is affected, or it can be a global tubular dysfunction, meaning the whole of proximal tubule is affected, meaning rest of your glucose, amino acids, sodium, potassium, those are also affected. And again in isolated and global dysfunction, it can be primary or secondary. Primary is proper tubular dysfunction. Secondary is there is a systemic disease or some other problem that is causing a dysfunction in proximal tubules. I will give two examples for each. Isolated primary can be genetic defects. Autosomal recessive generally have eye problems, and autosomal dominant child presents with short stature. Secondary is generally due to drugs, acetazolamide and topiramate. Global dysfunction, you know the classical Fanconi's. Fanconi's can have again associated systemic problems or without systemic problems. Global secondary drugs, of course, ifosfamide and tetracycline. There can also be associated secondary hyperparathyroidism and medullary cystic disease. In Fanconi's, without systemic disorders is genetic causes or sporadic defects. With systemic disorders, 2 amino acids, 2 carbohydrate and 2 mineral defects. Amino acid cystinosis and tyrosinemia, carbohydrate galactosemia and fructose intolerance. Your minerals are Wilson's and Dent's disease. What are the clinical features? See, clinical features are very similar for both proximal and distal RTA except few. The common features are growth failure. Why does growth failure happen? Because of multiple reasons. The child is going to have loss of nutrients, loss of electrolytes. Child is going to have defective bone growth because of acidosis. All of this will lead to growth failure. The child is going to have polyuria because loss of electrolytes automatically pulls water along with it. Because of loss of water, dehydration. Because of loss of dehydration, excessive thirst. Because of loss of salt, excessive craving for salt and savory food. Apart from that, this child can have vomiting, constipation, hypotonia, rickets-like feature. Rickets-like feature will be more prominent in distal RTA than proximal RTA. I will come to that later. And if the child is having specific systemic disorders or syndromes, they will have specific features of those. What are the investigations that you are going to do? From the previous discussion, you already know your ABG is going to show a normal anion gap metabolic acidosis. And if the child is having a Fanconi's or a global tubular dysfunction, rest everything also will be lost. What is your urine analysis going to show? Just remember, generally it is going to be acidic because distal acidification is intact. Urine potassium loss, yes, definitely it will be there. And urine electrolytes are going to be increased because most of them which are absorbed in proximal tubule are not going to be absorbed. Coming to distal lipidar defect. Okay, in distal tubules, what is the problem? Distal tubules are not secreting hydrogen ions into tubules. So what happens? Hydrogen is going to get retained. Since hydrogen is going to get retained in the blood, the child is going to have acidosis. Correct? There is also going to be increased sodium absorption because there is going to be loss of bicarbonate distally. There will also be potassium secretion because you know here there was a potassium hydrogen exchanger. Correct? If hydrogen is not going to go out, potassium is not going to come in. So if potassium is not going to come in, it is going to get lost in urine. So there will be hypokalemia. There will be hypercalciuria. This hypercalciuria is an important point that we need to discuss. Okay. So why does hypercalciuria occur? Hypercalciuria occurs, one, because there is going to be increased bone resorption. Why does this happen? Because of metabolic acidosis. So now the next question comes, see, proximal tubule defect also is having a metabolic acidosis. Why do they not have a hypercalciuria? They do have, but they will not have that much because the proximal tubule can still reabsorb bicarbonate after a specific value. So there will not be that much of a bone resorption and hence not that much of rickets-like features. Okay, coming back to distal tubular defect. There will also be hypocitraturia. What is the importance of hypocitraturia? See, citrate absorption will be increased during metabolic acidosis. So the proximal tubule, which is intact, absorbs more and more citrate whenever there is a metabolic acidosis. So what happens? In your tubules, there is a low citrate concentration. This citrate is important to prevent stone formation. So whenever there is a low urine citrate, whenever there is a alkaline urine pH, because there is no hydrogen in your urine, and whenever there is a calcium also present in urine, the calcium which is not going to combine with citrate is sitting free. This will combine with phosphate and form calcium phosphate stones. This can deposit in tubules, this can deposit in kidneys, causing nephrolithiasis and nephrocalcinosis, which is very classical of distal tubular defect. The causes of distal RTA. Similar to proximal RTA, divided into primary and secondary. Primary can be familial and sporadic. Secondary can be a tubulointerstitial problem like an obstructive uropathy or a chronic kidney infection. Autoimmune or an infectious cause like chronic active hepatitis or HIV nephropathy. Drugs and toxins like amphotericin B, ifosfamide and lithium. Genetic causes, meaning systemic genetic problems, not in kidneys, like Marfan's and Ehlers-Danlos loss. Clinical features, they are very similar to proximal RTA except your hypercalciuria and nephrocalcinosis, for which we discussed reasons already. So, your increased calcium losses, hypocytruria and alkaline pH all favor formation of calcium phosphate deposition. Lab features again are going to be very similar except your urine pH. Why is urine pH more than 5.5? See, your proximal tubules are functioning properly, so they are reabsorbing all your bicarbonate. Your distal tubule is not functioning properly and it is retaining all your hydrogen. So, the acidification of urine is not happening. So, your urine pH is alkaline. It is more than 5.5. Ultrasound kidneys are going to show nephrocalcinosis if present, and you can check for calcium excretion in urine by 24-hour urine. So, how do you approach or how do you suspect? So, any child who is having failure to thrive with polyuria, increased thirst, increased craving for salty foods and rickets-like feature, suspect renal tubular acidosis. Laboratory suspicion wise, normal anion gap metabolic acidosis with urinary pH abnormalities. Okay. The important caveat here is diarrhea. So, a child with diarrhea in our country, most of them they come with malnourishment along with diarrhea. So, you don't know whether the child is having a failure to thrive with renal tubular acidosis or a simple case of malnourished child with diarrhea. So, what you should do is, this child is still going to have multiple electrolyte abnormalities. This child will still be having metabolic acidosis. This child will still be having a normal anion gap metabolic acidosis. So, correct all those defects as you will with a diarrhea. Wait for the child to settle down. After few days, retest your electrolytes, retest your ABG. So, in the presence of normal gut function, if the child is still going to show electrolyte abnormalities, then work up. And among these differences between proximal and distal, the important points I would like to bring to your notice is urine pH. If you are going to give bicarbonate, what is going to happen? In proximal tubule, whatever bicarbonate you are going to give, most of them may not be absorbed. So, your bicarbonate concentration increases in proximal defect. In distal defect, it does not happen because your proximal tubule is functioning properly. It is going to reabsorb whatever alkali therapy you are going to give. So, a child with distal tubule defect, if you are giving an alkali therapy, will be very responsive because the acidosis will get corrected due to reabsorption of bicarbonate. Whereas in a proximal tubule, it is difficult to correct because whatever bicarbonate you are going to give may not get absorbed from the tubules. How do you treat? Of course, you are going to treat with bicarbonate or alkali supplementation. It can be given as a solution or it can be given as a tablet. Bicitra or Scholl solution generally have a 1 ml is equal to 1 milliequivalent base concentration. They generally contain citrate, which is easily convertible to bicarbonate. Sodium bicarbonate tablets, which are cheaper, is available as 325 and 650 mg, where 325 mg means 4 milliequivalent base. To be very exact, it is around 3.8, but 4 milliequivalents for ease of calculation. The dosage required will be very high in proximal RTA because absorption is going to be very less, and distal RTA will be 2 to 4 milliequivalent per kg per 24 hours. What is the importance of alkali therapy? This is going to correct growth. This will reduce calcium loss from bones because metabolic acidosis is getting corrected. It will reverse hypercalciuria again because there will be less bone resorption. It will reduce inappropriate urinary potassium losses and it will prevent loss of kidney function, especially in distal RTA. Apart from that, since both of them have hypokalemia, you are going to supplement them with potassium. Important point to note in potassium supplementation is this. See, especially in proximal tubule therapy, this child is having loss of bicarbonate and imagine you are giving bicarbonate to this child. So, after whatever is getting reabsorbed, rest are going to go to distal part of tubules, correct? So, this increased delivery of sodium, your bicarbonate and of course water which is drawn along with it. When it reaches distal tubule, what happens? It increases potassium secretion. Also, this child is going to be hypovolemic. That would have increased your aldosterone concentration. What will this aldosterone do? This is also going to increase potassium secretion. So, ultimately, this child is going to lose potassium if you give alkali therapy without potassium supplementation. So, in a child with proximal RTA, make sure your alkali therapy contains some amount of potassium in it, meaning give it as a potassium citrate so that the supplement has potassium in it. Apart from that, your phosphate supplementation in global tubular dysfunction. Thiazide diuretic can be given especially when there is a symptomatic hypercalcemia, a bicarbonate reabsorption, and potassium sparing diuretic can be added if you are suspecting potassium losses. Potassium before alkali, we discussed this.